right, David, I've got a pop quiz for you today.
I didn't study.
Some would say that's the point of a pop quiz.
Okay, fair enough.
All right, so tell me, what's the difference between an X-ray, a CT scan, an MRI, and an ultrasound?
I mean, I've had most of those. X-rays are about bones and ultrasounds are about babies and the other ones are about squishies. I don't know. I really don't know.
Well, okay, same. Before I started working on this episode, it honestly felt like straight up magic to me. Like you walk into this dark room, they put you in some machine or they point a machine at you and poof, they know exactly what's inside of your body.
Honestly, I think most people would not be able to tell you off the top of their head what the difference between a CAT scan and an MRI is. It's alchemy.
Right, but I think we should know. By the way, this is Smarter Than Cancer. I'm Hajar.
And I'm David Hoffman.
Most of us have gotten some of these tests done before, and I think we should understand how they actually work.
And I'm guessing you found some people who can explain it a lot better than we can.
I did. I sat down with 2 radiologists here at Roswell Park, and they walked me through everything. Not just how each scan works, but when and why doctors use them, what the risks are, and even some really cool new technology that's changing the field.
I'm excited to learn. Let's go.
All right, let's hear it. Today I'm talking to Dr. Craig Hendler, the Vice Chair of the Department of Radiology at Roswell Park, and Dr. Tom Laudico, the Director of Body Imaging. To start us off, I want them to go through the different types of imaging methods we have and when and why each one is used. Let's start with the ones that require radiation.
So one of the most basic modalities or types of imaging that we utilize is x-rays. That's if you get a chest x-ray, or if you're worried about a broken bone, you can get a plain film of your arm. These are kind of what I'd call forest for the trees, big picture types of things. They're not very good at finding little details, but they're good at finding big things like pneumonia, fractures, things like that. When it becomes more of a complex medical issue, then we do things like a CAT scan, which is radiation similar to an X-ray, but allows us to get cross-sectional imaging.
What's happening in the technology that's allowing that?
So basically in a CT, we have an X-ray machine that kind of rotates around the patient with detectors, and that allows us to get multiple images of the entire axial image of the patient, of the cross-section of the patient, and get more data-rich information to show the detail of the anatomy.
So then, this is probably a stupid question. Can I ask then why x-rays are still relevant? Like, wouldn't we think, okay, we have a more advanced technology now. Is it more harmful?
No. So an X-ray allows you to get a quick answer to a lot of your clinical questions. So
with less radiation.
With less radiation.
Than a CT
so
scan.
Yes, much less radiation. A lot of times you'll see this in urgent care settings where somebody comes in with a child with a cough and they're worried about pneumonia, and you can get a quick answer and a fairly accurate answer as to whether they have pneumonia or not, which would change their treatment. The ability to quickly get it, as well as the ability to save on radiation, would be the 2 reasons why we utilize it, usually as our first run.
And where the insurance companies love it, X-ray is cheaper. So if you can answer the question about pneumonia using an X-ray, you've saved the patient dose and you've saved some money.
Both x-rays and CT scans rely on radiation. But that always felt like magic to me. How do beams of radiation go through our bodies and produce an image that a radiologist can look at? What is happening in the technology that allows for that?
You're basically using the ionizing radiation or the electrons to penetrate through the body. And then on the opposite side from where you sent the electrons, you're picking up how were those electrons affected on the other side.
Where are the electrons coming from?
So you're bombarding a known piece of metal, it's usually tungsten, with electrons. And you're exciting other electrons from the tungsten that then come out, and you're using that to go through a patient. But they're at many different energy levels, from very low to very high. And over time, we've learned that there are very specific energies of these excited electrons that go through your body that are very useful in producing an image. And what do I mean by that? If they're very low energy, some won't even be able to penetrate your skin. So they're not doing anything because they're not able to even get through you to make a message. Some are so high, they're going through as if nothing was between their source and their detector. So based on the density, you're building an image, let's say bone. We all know bone is very dense, or you wouldn't be able to hear me knock on a door. So the computer is able to detect high energy beams are coming in here, lower ones are coming in here. This must be bone, this must be fat. They all have different densities. And that's all you're doing is what gets through, and it knows what it's sent out, it knows what it's detecting, and it uses those differences on the detector side to recreate an image. So it's creating a density picture. And that's so hard to explain. I mean, we take a whole, in our first year of radiology residency, we take a year-long course in physics, and then we have to take a test on it. So it's not an easy concept to explain. I mean, a physicist would be able to explain it significantly better because that's all they do all day.
Okay, without a physicist on call, here's what I understand. Radiation gives us this really useful clue about the density of whatever it hits, whether it's bone, muscle, fluid, and because radiologists have interpreted these patterns for decades, they can look at an image and understand exactly what's going on. But most of us have also heard that radiation is kind of bad for us, right? So are we putting ourselves at risk every time we have to go and get a scan?
I think with the chest x-ray, I believe that radiation is equal to the exposure of taking a flight from New York to LA, approximately. So that kind of gives you an idea. You are exposed to radiation levels similar to a chest x-ray if you fly frequently.
Wow.
So it isn't something that's trivial per se, but it's not anything that's going to cause any major issues. Certain parts of the body are less radio sensitive than others. So when you get an x-ray of your hands, it's less concerning than your chest or your abdomen pelvis. So there are differences in the radiation exposure tolerances of different body parts.
And usually the risk that people worry about, it's a lifetime risk. It's usually not risk based on a single scan. It's how much radiation have you had over your lifetime. So one thing that radiologists attempt to do is limit imaging as much as possible. Like it'll get our attention often when we're scanning patients, unfortunately, here at Roswell Park who have cancer and who are coming back. They're getting scans every 3 to 6 months, and they're CT scans, so it's more radiation.
Yeah.
But the balance is made. If their cancer is progressing, you really want to know. And it's more important that we know that there's an issue so that we can intervene or change therapy.
We're constantly looking at techniques for dose reduction. One of the most common things that we do is chest CT, and we have a low dose protocol where the makers of the CT device, they have ways to lower the radiation dose. There's algorithms that they can utilize to get imaging that is adequate, but doesn't expose the patient to unnecessary radiation. So a lot of times with lung cancer screening being a great example, these are healthy patients that are coming in. They don't have cancer. They're just looking for a screening. So we want to keep that as low as possible. Similar with pediatric patients. It's called a LARA, as low as reasonably achievable. Mm-hmm. So we're trying to keep the radiation dose as low as possible across the board.
So that's the world of radiation-based imaging, x-rays and CT scans pretty much. But radiation is not the only way we can look inside the body. There are other forms of imaging that don't require radiation at all.
Ultrasound is another cheap form of imaging. It has no radiation. It uses sound waves. So basically, the probe that you place on the patient, like if anybody's familiar with seeing how they scan to look for a child and a pregnant woman, the sound waves go in and then they reflect back. And it's just the difference in how they come back to the receiver. The probe that they hold sends the sound wave, but also retrieves them back. Yeah. It's not radiation. And the different tissues, it bounces off tissues differently. So again, just like we talked about with x-ray, the way the sound waves come back with bone is different from muscle, is different from fluid, like in your bladder. So the machines are able to create an image based on that to tell you what you're looking at. So that's a pretty neat way of imaging. Again, no radiation, so there's no harm, and it's pretty inexpensive. The problem is you don't get really any significant detail. So we're using it to look for, similar to x-ray, big problems. Do you have a large mass coming off of your kidneys? Do you have a blockage in your kidney? Usually if we find something, we go on to one of the more improved methods of imaging, CT or MRI.
So MRI doesn't require ionizing radiation, essentially using a magnetic field and the way that soft tissues in the body react differently to that magnetic field, it allows the computer to generate an image based on that information. It gets quite complicated in terms of the physics, but that's a general explanation of how it happens. And we utilize that for a lot of our difficult lesions because it gives us a lot of different pictures, a lot of different characteristics that we can use if we manipulate the settings in MRI. Can allow us to tell if something is a tumor versus something benign, just based on utilizing different techniques with MRI. So it's a great problem solver is how I would describe it.
And we used the other modalities first because a couple of the drawbacks from MRI is those exams can take quite a long time. So they could take anywhere from 30 minutes to an hour and a half. A CT scan will take, once the patient's on the table, 30 seconds, maybe a minute at the most. And the expense, it's much more expensive to get an MRI than it is to get a CT. So you're trying to use the cheapest methods first, the ones that give the least amount of radiation first, and you work your way up because you're trying to still solve that problem by not just jumping to the most expensive.
MRIs are an incredible, powerful tool for radiologists, but for some patients, they're also really uncomfortable. If you've ever had one done, you've probably experienced this loud, banging noise that can cause anxiety for many.
So the gradients in the MR is what you're hearing, that pinging sound. And a lot of patients do have issues with that, but we do have headphones that we allow them to wear, and it pumps in music and kind of distracts them from it. But, sometimes it's just a part of the technology and you can't really do much about it.
The other thing is the design. MRIs are done in these long, narrow, cylinder-looking machines. And for people who are claustrophobic, you could imagine how anxiety-inducing that is.
There are some MRI units. I have a family member who's claustrophobic, and I think he can sit in it, and it allows his head to be out if they're looking at his chest or his abdomen. They tend to not be as good. Because of the physics with MRI, that's why the tube that you're going in is smaller and it's longer. And there are a lot of issues with claustrophobia. It is important for the physician who's ordering them to be aware of their patient's needs. And by that, I mean, if you know you're ordering an MRI on somebody, my next question, if I were in the office, would be, do you have any issues with claustrophobia? Because I might want to pre-medicate you.
Okay, so a scan is made. Could you tell me what a radiologist is then seeing in that image? Because what we see is just black and white blobs.
On X-ray, there's really 2 or 3 basic densities: white, black, and gray. But you'll know white is bone, black is air, gray is soft tissue. So we're taught how to interpret what that means. CT is a little different. It's a higher level computer generation, so it can tell muscle from fat, from bone, from air, from anything in between. I mean, the way we look at the world is on CT and MRI is if someone's laying down and you're looking at as if a magician put a knife through you and separated you. That's how we're looking into the body. We call them axial slices. And the computer just takes all the axial slices and it just gives you all the data. So it'll go from, let's say it's an abdomen. It'll start at the very lung bases and go through just at the top of the pelvis. And we'll see on every patient, unless they've had surgery, liver and spleen, the bowel that's in there, the kidneys, the pancreas and all that. But you're seeing them whether we gave contrast or not. So we're going to see different sequences, one without contrast, one with contrast, one with this type of algorithm, one with that type of algorithm. They will also often rebuild them so that I can see it as if you were standing up. So I'm looking in your body as if I cut through from your head to your feet. Sometimes from the side, they call it sagittal. So we're just looking at the body from different projections. It's almost like watching a baseball game from first base, third base, and outfield. You're looking at the same event, but you're looking at it from different views. And you're just interrogating each organ separately to make a determination of what's going on in the liver, what's going on in the pancreas, how is that affected.
What may look like a blur of shapes and gray tones for most of us, for a radiologist, someone who's trained in anatomy and pattern recognition and physics, that's a detailed map of what's happening inside of our bodies. And those subtle differences in densities and contrast, they can tell them exactly what's going on and guide a diagnosis. These tools have been the backbone of medicine for decades and decades and decades. And recently, there has been new technology introduced that can make a radiologist's work even more precise.
I mean, some of the software that's out now is very useful to radiologists and assists us. A lot of the times, all the anatomy can line up. If I look at something on a chest CT, let's say, that has some images of the abdomen, and the last CT I had was an abdomen, it'll find the same slice on the prior study and allow me to compare it across multiple exams. Things like that are very helpful. And There's other software that's coming out, like that pulmonary nodules can be measured and then compared to prior studies, and they can measure out the growth curve of those nodules and tell us how worried we should be about this being potentially cancer.
It's applying high-level mathematics to the imaging, which is something a radiologist could do just sitting at his workstation.
Mm-hmm. Yeah. So because of the pattern recognition part of your job, I'm imagining that AI has entered the picture. What do you think about that? Like, I've been hearing a lot about these AI mammograms. There seems to be a lot of hype around it.
Well, it is out there in mammography. They have something called computer-assisted detection. So basically, you can teach the computers to detect differences in tissue density. So you can teach a computer bone versus fat versus muscle versus air. So then if you're imaging a breast and it's supposed to be soft tissue and fat and it detects something else that's either higher or lower and they can set the specifics, the computer is going to tell you there's something here. You can see it. Where the radiologist still has great value is the experience. So then the imager sees, it circles the lesion, and you look at it and say, that has a typical appearance of and can put a better name to it than just, this doesn't belong. The computers will get smarter, but especially at a cancer institute where oftentimes the anatomy of the patients change because of surgery and or radiation, it'll be harder to teach computers those alterations. You can teach it the norm, but not, again, no two people are the same anyways. Especially if you're talking about mammography, there are multiple densities of breast tissue, which can make those detections very difficult.
I think that people don't understand what radiologists do because I think we're in the background. We're the guy that no one sees.
Yeah, and even though we're unseen, we used to be called, I don't know if people still use this term, we were the doctor's doctor, meaning when they want to know something, they're going to ask us because we have the images and we can tell them exactly what's going on. I will say the physicians at Roswell are remarkably well trained.
They work with us.
They're so well versed. They can look at the images and they know mostly what they're looking at. I mean, they're just exceptional here, but they do rely on us for those small things. Like, what's the difference between what I'm seeing here and here? And they'll come and ask us, but that's really our role, is to keep guiding therapy from the inside out.
So that's something that really surprised me while talking to Dr. Hendler and Dr. Laudico. I've gotten scans done before, but I never realized how involved radiologists were, how much cooperation there is between doctors and radiologists. But I've also never gotten them done in a comprehensive cancer care center like Roswell Park. So I wanted to understand, is this level of involvement unique to places like Roswell Park?
I think that at Roswell, the great thing about this institute is that when you come here, it's a team effort, right? So you have a primary doctor, but that's not where it stops, right? We have pathology, we have radiology. Everyone works together in concert to take care of the patient. Whereas if you're in an outpatient center, I'm just reading your case. I may not know all the details. I can't call up the surgeon and be like, listen, these are the things I'm seeing. I wanted to discuss the case with you because you know the patient best. And we can come to a more accurate determination of what's going on with the patient. Whereas if you're in a private practice, you just have the images and that's it.
And private practice tends to just read at a higher volume. So their desire to slow down in a day is not as great as ours. Like, we will do whatever we can. We constantly call the oncologist or the surgeons or the radiation doc. We call each other. Cancer doesn't always fit in a neat little bucket. Cancer diseases, they don't read textbooks, so sometimes they don't look like you're trained that they're supposed to look. So I may see something and I'm like, I am not sure I'm seeing this correctly. And I'll get him on the horn and I'll get somebody else on the horn. And we'll all kind of look at the images because we're just trying to guide that therapy. You get that here, you won't get that.
Yeah. This is, I think, the most remarkable thing about being here. I think a lot of people get really frustrated. Like, I'm sick. I don't want to tell you what this person told me. Like, figure it out.
Yeah, we all talk to each other. And one of the ways we do that, we have this what's called a multidisciplinary conference, where the most challenging cases, we show the images and the pathology. And we have somebody from surgery, from medical oncology, from radiation, from all the different aspects of the patient's treatment algorithm, all in the same room talking about it, which is unique, but it allows us to really give the patients the best care.
Thanks for listening to Smarter Than Cancer, a production of Roswell Park Comprehensive Cancer Center.
The show is written and produced by your hosts, Hajar and David Hoffman.
Production oversight by Peter Sosha.
Additional logistics and support from Michelle Eisenstein.
Our production partner for this series is Citizen Racecar.
Post-production by Gregory Schweitzer for DCP Entertainment.
Publication and promotion supervised by Candice Chanteloup. If you or your loved one has been diagnosed with cancer and would like to schedule an appointment with Roswell Park, please call 1-800-ROSWELL. That's 1-800-ROSWELL. Or visit us at roswellpark.org.
If you're enjoying this series, we'd love to hear from you. Please reach out and tell us about your cancer story, and let us know what topics you'd like us to cover in future episodes by filling out the form at roswellpark.org/smarterthancancer.
And if you know someone else who might find value in what we're doing, please tell them about it. You can listen and subscribe wherever you get your podcasts.